Hi everybody, and welcome to our module on liver tumors. As we'll talk about later, most cancers that occur in the liver are metastatic from some other part of the body, but we're going to begin today by talking about primary liver tumors, and the most common primary liver tumor is called a hepatocellular carcinoma. And patients who develop hepatocellular carcinoma usually have a history of some type of chronic liver disease. Chronic hepatitis B and C are common etiologies for hepatocellular carcinoma, so is alcoholic cirrhosis. Wilson's disease and hemochromatosis are rare disorders, but when they do occur and they have liver involvement, these patients can develop hepatocellular carcinoma. And then finally, alpha-1 antitrypsin deficiency is something that you may think of as a lung problem, but it can also have liver involvement and lead to cirrhosis. And people who are born with an alpha-1 antitrypsin deficiency and have liver involvement can go on to develop hepatocellular carcinoma. And this is a gross picture of a liver with a hepatocellular carcinoma tumor. You can see there's a large tumor growing inside the liver tissue. This doesn't happen much in the United States, but in developing countries, many people develop hepatocellular carcinoma from exposure to a toxin produced by the fungus Aspergillus. This fungus produces a toxin called aflatoxin, and it can contaminate corn and soybean and peanuts. And if you eat a lot of corn and soybean and peanuts that have been exposed to the aflatoxin from Aspergillus, you can develop hepatocellular carcinoma. Now, in industrialized countries like the United States, screening is done so that aflatoxin does not get into the foods that we eat. However, patients can have exposure if they live in a non-industrialized country or if they eat lots of locally grown foods. Hepatocellular carcinoma, especially in the early stages, is often asymptomatic, and the key is to do screening of high-risk patients. So people who have chronic hepatitis B and hepatitis C infections are screened regularly for development of hepatocellular carcinoma with imaging studies. You can check the liver function tests, but they're variable. Usually they're abnormal in a non-specific pattern. And as we talked about before, most patients who get this cancer already have liver disease, so abnormalities of the liver function test won't help you in determining whether they have converted to the development of a hepatocellular carcinoma on top of their chronic liver disease. The liver can become enlarged when the tumor gets very big, and then eventually, if the tumor is large enough, it can cause liver failure with obstructive jaundice and ascites. Large hepatocellular carcinomas characteristically cause hypoglycemia. This is seen with large tumors because they have a very high metabolic rate and they consume lots of glucose. Additionally, rarely, tumors have been described as producing a hormone called insulin-like growth factor 2, which can function like insulin. And then finally, when the tumor gets large enough, it can just destroy so much of the liver tissue that there aren't hepatocytes available to perform gluconeogenesis during times of fasting. Hepatocellular carcinomas are also well described as causing erythrocytosis. This is because they can sometimes secrete erythropoietin. And then a dangerous complication of hepatocellular carcinoma is called the Budd-Chiari syndrome. This occurs because in the setting of hepatocellular carcinoma, you have a hypercoagulable state from the presence of a cancer, plus there is compression of venous structures in the liver. In particular, the tumor can compress the hepatic veins that drain the liver, and this can lead to a blood clot in the hepatic veins. This means that blood will not be able to flow out of the liver. And the Budd-Chiari syndrome results in a characteristic triad of abdominal pain, ascites, and hepatomegaly that has an abrupt onset when the tumor compresses the veins and a blood clot occurs. Hepatocellular carcinomas secrete alpha-fetoprotein, and it would be nice if we could use this for diagnosis, but unfortunately, AFP levels can also be elevated in patients with chronic liver disease, and as I told you before, this cancer usually occurs on top of chronic liver disease. What you can do is monitor the baseline levels, and if there is a rise in the AFP level, that can be suspicious for the development of hepatocellular carcinoma on top of chronic liver disease. Often these tumors are diagnosed by imaging. You can see them on CT scans or MRIs or ultrasounds of the liver. Patients who have chronic liver disease, as I told you before, are often screened regularly to try and diagnose this tumor early. And then finally, you can always do a biopsy, and this is the way to definitively diagnose the presence of cancer cells in the liver. Metastasis of this tumor is relatively rare at the time of diagnosis. Only a few % of cases have metastasis. The tumor usually spreads via the blood, not the lymph, and it likes to spread to the lung and the bones, especially the lung. And you may know that the blood drains from the liver to the hepatic veins and the IVC, and that goes straight into the lungs, so it makes sense that the lungs are a site for metastasis. The treatment of hepatocellular carcinoma is complex, but one thing that's easy to remember is that this tumor is notorious for being poorly responsive to chemo and radiation. Those treatments which are used in many other tumors do not work well in hepatocellular carcinoma. Surgical excision is an option, but it's often not possible because the tumor is so large that you would essentially have to remove the patient's entire liver. Liver transplantation is sometimes done. As I told you before, this tumor is often not metastatic. That means it's contained in the liver, so you can essentially take the whole liver out and put in a new liver if a transplant organ is available. Sometimes these tumors are treated with radiofrequency ablation. This is where you use radiofrequency thermal energy to try and destroy the lesion. Basically, it's a targeted therapy at the lesion to try and destroy just the tumor and not the liver tissue around it. A similar and related therapy is called chemoembolization. This is where you inject a procoagulant directly into the tumor, hoping to kill the tumor cells and not the liver. Overall, the prognosis is poor, and the median survival after diagnosis is 6 to 20 months. Now I'll talk about other liver tumors, and let's start by talking about hepatic adenomas. These are benign liver tumors that derive from epithelial cells. They are usually a solitary tumor in the right lobe of the liver, and they're common in women from the 20s to 40s. Usually these do not cause symptoms. They are rarely symptomatic, and they're often picked up incidentally when imaging of the abdomen is done, working up some cause of abdominal pain. They have a couple of associations you should be aware of. First of all, women who take contraceptive pills often develop hepatic adenomas. This is a picture of oral contraceptive pills on the screen to remind you of this fact. They are also associated with taking anabolic steroids. So some weightlifters take anabolic steroids. Also, some transgender individuals take anabolic steroids to increase muscle mass, and these groups of patients are at risk for hepatic adenomas. Now, as I mentioned, these tumors are benign and they are rarely symptomatic. The only time they are sometimes a clinical problem is during pregnancy. There are case reports of hepatic adenomas that rupture during pregnancy, and a very tricky clinical scenario is a woman who has an established hepatic adenoma that is asymptomatic, and that woman becomes pregnant. This is the one case where these tumors are sometimes excised or ablated in order to prevent rupturing during the woman's pregnancy. Hepatic hemangiomas are also sometimes called cavernous hemangiomas. These tumors are the most common benign liver tumors. I told you that hepatocellular carcinoma is the most common primary liver tumor overall, but among the tumors in the liver that are benign, this one is the most common. It's composed of vascular spaces often filled with thrombus, and that's easy to remember because it has the word heme in its name. It's often discovered incidentally at surgery or on imaging, just like hepatic adenomas. And there are case reports of fatal hemorrhage with biopsy. Remember that these tumors are made up of vascular spaces. So in general, biopsy of these lesions is not recommended and should be done with great caution. Angiosarcomas of the liver are very rare, but they are malignant vascular tumors. So they are vascular like hemangiomas, but these tumors are malignant. They present with symptoms like abdominal pain, jaundice, ascites, and weight loss. And these are very rare tumors. The reason they're going to ask you about them on your boards is because they're associated with certain toxic exposures that you need to be aware of. Vinyl chloride exposure can lead to angiosarcoma. Vinyl chloride is used to make PVC plastic. PVC stands for polyvinyl chloride. It's a very common type of plastic. This is a picture of PVC piping, which you may have seen around a construction site. And if you work in areas where PVC pipe is synthesized from vinyl chloride, you can be exposed to vinyl chloride, and inhalation can lead to angiosarcoma. A second exposure that can lead to this tumor is arsenic. Arsenic is found in rocks and soil and water, and certain geographic areas have very high levels, and there are many industrial uses of arsenic. And if you have a high level of exposure to arsenic, you can potentially develop an angiosarcoma. And these are probably the two most important facts to know about this very rare liver tumor. I'll finish by mentioning metastases to the liver from other places in the body. As I told you at the beginning of this module, metastases are much more common than primary liver tumors. They're much more common than hepatocellular carcinoma, which is the most common primary liver tumor. Places that like to send metastases to the liver include anywhere in the GI tract and the breast and the lung. And the GI tract has always been easy for me to remember because you may know that the GI tract is drained via the portal vein to the liver, so you can just think of all those structures like the colon, the stomach, and the pancreas sending mets to the liver in the same manner. Finally, the way you can recognize metastases to the liver on imaging is that you will usually see multiple nodules. So this is a picture of metastases to the liver on a CAT scan. You can see one nodule here, another one here, another one here, another one here. This is not going to happen from any primary liver tumor. Primary liver tumors will usually be solitary. When you see multiple spots like this, it usually is a metastatic cancer that is sending mets to the liver. And that concludes our module on liver tumors.